we are talking about double filtration plasmapheresis, the circuit components and workflow. DFPP, just like plasma exchange, removes immunoglobulins. The advantages of DFPP are it is highly selective, the replacement fluid required is much less, and hence it also ends up being more cost effective as compared to plasma exchange. The key components of the circuit are there is a vascular access that takes blood through the blood circuit. It first passes through a plasma filter, a typical plasma separator. The plasma separated then passes through a plasma fractionator, which separates the large molecules like immunoglobulins, which are excreted, from smaller molecules like albumins, which are returned back. Here you can see in the image two boxes. To your left is the typical plasma filter which we use for membrane plasma exchange, and to the right is the EVA-flux filter, which is the fractionator. Now this circuit basically consists of blood passing from the patient going through the first plasma filter, where the plasma which is yellow in color is separated and the rest of the blood components are returned back. This yellow plasma then goes through a plasma fractionator, which separates the smaller molecules through the filtrate from the larger molecules. These are the double filtration plasmapheresis we are going to do now. We have the two machines in parallel to each other. The first machine has our normal plasma filter, the P2 filter, normal dialysis circuit. This one has the EVA-flux 2A filter. Just explaining the connections first. So this machine, the blood will come from the patient, right, Nish?
This is artery.
Artery. It will connect to the pump. Through the pump, it will go to the plasma filter.
Then
the venous end of the plasma filter,
blood will go
return to patient. Now,
and after separation, plasma.
The separated plasma is connected to the arterial limb of through the pump to the EVA filter.
EVA flux.
Yeah, and then
after filter, it will go to
the filtrate, which will separate the small and the large molecules. So the small molecules, we return it back to the patient,
artery,
to the venous chamber, from where it will go back to the patient. And the efflux, which is the larger molecules which are coming from here, through this drip, through this infusion pump, we are controlling the rate of efflux, so that the pressure in this circuit is maintained, and slowly the drain will come out, which will contain mostly the large molecules and the immunoglobulins. So this is the circuit for the double filtration. Now Dinesh, correct me if I'm wrong. So this is the blood coming in.
This is coming out.
Coming out.
Artery.
Coming out the arterial, and it's coming now through the pump.
Will pull out
through the pump, and we have kept the speed of the blood pump, the first blood pump, at 150.
150 to 180 max.
Yeah, 150 to 200 up to we can keep based on how much you are planning to remove. Then this goes.
Is plasma separate P2 filter.
This is the P2 filter, right? So this is going into this filter, and then from the P2 filter, this is coming out. The out from the P2 filter, the venous is going back. Now this is the plasma separator. So the plasma is getting separated in the filtrate. Now this filtrate is connected to the arterial limb of the second filter.
Second machine.
That is,
So we
here
are keeping pump speed approximately 30 to 40 or 20.
Correct. Has to be 1/5 of the pump speed of the first filter.
5
Since we kept 5:1 ratio. So if it was 150, you will keep this 30. If you kept that 200, you keep this 40. So then this goes through this pump at 30 ml per minute into the arterial limb of this, the EVA filter 2A, which we are using for our transplant purpose. Now here, the tricky thing which I saw you do was, you keep the venous limb clamped till you get the entire filter with the filtrate. Yeah, when it becomes yellow basically, when you know that it has come up, because the speed is so low. By seeing visually, you can see when the whole thing came all the way up. Till then you kept the venous limb clamped. So the venous limb was clamped. The filtrate limb, which is separating the smaller molecules, is coming here. Smaller molecules like albumin is coming here, and it is connected to the venous limb of the plasma filter wala.
So it will
go back to the patient, right.
Then this is removal.
This is the removal. The removal is actually from the venous limb. The filtrate is going back to the patient, but the removal drain is from the venous limb, and we rate control it because we don't want very fast removal. And
150 ml per hour to 200 ml per hour.
that's it, 150 to 200 ml per hour, and we are getting that drain come out here.
So,
And your replacement to the patient is there. So because this is coming out at such a slow rate, you are replacing saline or RL to the patient initially. You have kept, and then later this we will replace this directly to the patient, either through a triway or in the venous limb. Connect here, exactly. We can connect it to the patient, right? And later on we'll give one, because we are only planning to remove about 600 to 800 ml. So we'll give one saline, one albumin, and if in IVIG you are giving, then you can give that towards the end. That is about our double filtration plasmapheresis filter circuit.